Now I will take up the idea of this type 2B autoimmunity by using a test where I have learned it's not available for Sabine anymore since she is no longer working in Berlin, but it would be available to you. So what is the role of the BAT, so the using of donor basophils with patient serum to find these autoreactive serum factors? So why should you use it? It's first of all in a floppy way in the guidelines. It says that it would give you more clarity, which is then no further defined, what the clarity means and what it's actually needing and meaning. And you should be guided by the test on what you further work up or treat. And then there's a recent publication which was a systematic literature review where in the end 42 studies were included to see if there is a relevance to a basophil activation test in this very frequent disease, and they conclude that either the histamine release test or the basophil activation test, which seem to rely on the same mechanism, point to a more active or more severe disease and should therefore be implemented in routine clinical care. So they are more precise than the current guidelines. I don't know what the update will make of it. Of the guidelines may take this up. And a very recent study where they did the autologous serum skin test again in a very experienced group in the northern part of Italy, where they could show, and it should measure kind of the same pathophysiology behind, so the serum test as well as the basophil activation test or histamine release test. It showed that, and this is in line in what you have shown, Sabine, that there is a slower response to omalizumab because it's a different disease type, subtype. So you can already tell your patient you have this positive test. It will most probably take 3 to 6 months until you will probably then respond to the treatment. So don't be disappointed after the second and third and don't come back or whatsoever. So how can you use it in your routine? First of all, you don't start off with the basophil activation test. This is, of course, not the way to go in any clinic, maybe besides the LTT that we've discussed in the morning, but for this more relying on donor blood test, we should be sure what we are doing. So there's this 7C schedule that is, or scheme that is recommended. And for the confirmation, Sabine, you have not alluded on that, but of course you look for the differential diagnosis. So you start off with the same disease. If you get into this workup diagnostically, you look for those two types that you have so perfectly alluded to, and then the cofactors. So can I avoid something? You were quite pessimistic that one finds some, but at least you can advise your patient on the painkillers and on other typical aggravators and triggers, and the comorbidities where these inducible forms come up and the autoimmunity of a different type, thyroid or elsewhere, and the consequences that it might have and how you want to tackle this. And at the very end, you might then want to know which type is actually in front, which type of CSU is the patient confronted with. And there you have seen this already, so I skipped this. You can either look for the dermographism for the inducible forms, then do this simple blood test for infection, for activation of the immune system of type 1, so which is CRP, and then do a skin testing. This physical skin testing, it has been professionalized by the Berlin group with different devices. So there are spin-off companies from the University of Berlin that offer such devices to test for. The tryptase, it was not mentioned up till now to at least exclude a higher number of mast cells or even mastocytosis if it's not already obviously visible, but we will have a mast cell specialist just afterwards. Then as an primarily trained in internal medicine, I would advise not only to measure anti-TPO, but the thyroid function test as well, so not to then do not really find a treatable disease, even, and that is interesting, even if you treat the thyroid disease, the urticaria usually does not improve by treating the underlying or bystander disease, but I think we shouldn't miss it if we look for it. And the autoimmunity can either be tested by the skin test or by the basophil activation test. And don't forget to consider biopsy in an atypical presentation, so that the single wheal is more painful, not so itchy, it stays for longer than 24 hours, it has a more bluish, dark red appearance, so not every wheal is just a simple histamine wheal, so you don't miss vasculitis, which needs a completely different treatment. So what can you tell to the patient after this encounter? Because of course he or she wants to know how this whole thing will go on. So there are some markers that you can already take up. So if there's an angioedema, usually it is that the whole disease is of a longer duration, even if it's angioedema alone or in combination, and it's worse in combination. So if you have the wheals and the angioedema, you will have it the longest. If it's very easily inducible on skin, and if there is this positive test on the skin. And this is what the test actually is. So you use the untreated serum sample of the patient. Don't try to mix it up with other patient serum. Put it into skin, usually on both arms, and usually twice per arm, maybe even in a dilution of 1 to 10 to see if we can dilute the reaction. And this is tedious, as you have alluded to, and it is a bit risky. And I can tell in a private practice with a high frequency of patients, it's just not working, because you would need one collaborator who is really waiting while the thing is centrifuged, so there's no mix-up in between. And so he's fully occupied, he or she is fully occupied with this test. So the idea is to find those factors which are activating the mast cells in the skin and the basophil in the blood. So why not use a different material than the patient's skin itself? So this is when the donor basophils come into play. So those are standardized or well-defined donors who give blood regularly, and then a batch of serum samples is tested on them in the standard testing procedure of a basophil activation test, which looks like this. So the open curve is the resting state of the basophils, and if they get activated, they show a different marker on their surface, which in this case is CD63, which is directly linked to histamine release. Means that the histamine-rich granules have fused with the membrane and histamine has been released. And this is a test which is quite straightforward, and it's best done with a batch of serum samples. And this is also nice in contrast to the test on the skin. You can of course batch them, collect all the serum and make them all at once, because you need only these donors. Which is quite important to what's quite important to mention as well is that if I do the test with my blood and with Sabine's blood and with Karin's blood and with Werner's blood, it's not by definition the same result, because in these artificial conditions in the lab, my blood needs a little bit of kick to get to the same level as maybe Sabine, who does not need IL-3 as an activating factor. Werner doesn't need anything. He's already activated in resting state. So unfortunately, he is not applicable to be used in this test. But you need to normalize between the different donors, so you are not relying on one donor alone. And you have to be careful if you read the literature, if in this specific study different donors were used, or as it's mostly the case, only one donor was used. Then you of course have a very nice result, but as a routine lab, you cannot rely on one single donor if you want your collaborators to stay with you longer. So we have an array of donors. It's between 10 and 15, and Kevin is very active in always getting new, so we can exchange if they move elsewhere, so that the single donor only comes around like every half a year. And with this, you get the result like this. So you see 86.6% of cells were activated, which is an SI, which you already know from the LTT of 18, which is strongly positive. These are the values between weakly positive, positive, and severely positive or highly positive, which we developed when we developed a test with a set of standardized patients where we had all the ASST results and could compare to it, and those were statistically the dividing measures. So to summarize and to get on to the future now, because this is all present, it may substitute for the ASST. We are fortunate to have the test at all. I learned from, as I said, from Sabine, that currently in Austria it's not available. It can give you some information on the prognosis of the disease, on the response to omalizumab, which is the treatment of choice, of first choice in the severe forms, and it can also give you clues on pathogenesis. And for us, let's say from year to year, we invest more in this field to learn on the pathophysiology, because you can play around with the donor basophils. You can block certain pathways to see if it's really mediated through the IgE-Fc epsilon receptor pathway, if it's either a G protein coupled mechanism, and to learn which of the different mechanisms that you have shown is actually activated in this patient. And your former boss, Markus Maurer, said about 3 years ago that basophil test is for him the best, because it's the most standardizable test currently available. And in contrast to the IgG measurement alone, which is about the same as Yannick has said, IgE measurement alone, you do not see the functionality of the IgG in serum if you only measure it in serum. Actually, it's not the biologically active one, but if you see that it's actively degranulating the basophils in vitro, you can then maybe translate it to a mast cell activation in the patient. So, of course, you not only do the test, I hope you have seen this, you do a simple lab after being sure that it's truly an urticaria that you see. You replace the more tedious test through a lab test, which is easier by just blood taking, and you see with the treatment response if you are on the right course. With this, I first want to thank the Inselspital, with whom we work very closely in this matter, especially Lukas, who is here, and the other part is the practice where I am working. And if you want to know more about the team who is actually performing the test and how the test is done in the lab, please look it up in the internet. I'm happy to take your questions.
When your CU pad is positive, can you say you have chronic urticaria type 2B?
Yeah, not if you only do this. There has been several research studies on preparing the serum before you use it on the basophils. So depleting it of IgG, doing it again, as I've told you before, then also trying to block some signal pathways. What you can say that there's autoreactivity, not necessarily directly pointing towards an IgG alone. And what we also found out that not rarely you need a second signal. You need like this underlying activating IgG, and then I haven't alluded on that, I have 15 minutes. The eosinophils also seem to play a role, because their products which they release in the tissue are activating this MGXRP2, this other receptor. So the mast cell receptor, which is not present on the basophils, which can, or to a low amount, only if they are strongly activated or pre-incubated with IL-3, they also express the same receptor.
If I would like now, I would like to sub-classify my chronic urticaria patients, type 1, type 2.
I don't hear you.
Type 1 or type 2B. How do I do it?
As I've told you, this is, I know you are very exact, so I have to give you an exact answer. But for the current standing, this helps me with the positive test. I go to the patient and tell him you have a more active, a more severe disease. Most probably there's autoimmunity involved. We also find these other markers like the anti-TPO. You will have to face a longer duration of your of your disease, you will need, I quickly go up to the omalizumab, I don't play around too long with the antihistamines, and you will most probably stay on the omalizumab for longer and have to be patient when we start the treatment, that it will take 3 to 6 months until it works well. But we expect it to work well, and we have other things in the second line treatment like the cyclosporine or the long list where we play around for different other forms of treatment.
2 to 3 decades ago, the chronic urticaria has been associated with basopenia.
Yes.
Have you ever seen blood samples without basophils?
Yeah, basopenia is often seen. The problem is that your standard hematometer is not very precise in measuring basophils. So it is good for neutrophils, it is quite good for the eosinophils, but the basophils, it does not perform well. So the numbers you get only from the scattergram are not very good. We tried to compare it and see how well it works. It didn't compare well to the CCR3 marked, which are clearly basophils, and the numbers we get from the standard hematometer. So this is problematic already from the start. But you can go for it. They are usually very low in the peripheral blood and they can be away, but if you want to be super sure, you have to stain them. That's not available for the standard measurements.
Yes, I'd have a question as to the time point when repeating a CU-BAT on omalizumab treatment. We start omalizumab according to the guidelines, and after having excluded not only urticaria vasculitis, but for example, neutrophil urticaria, which is also not responsible well yes. to not responding to antihistaminics and Xolair, but then Xolair will be given at least also according to the compendium for 3 months. You cannot tell patients that it will heal earlier than this. Up to 6 months according to the guidelines, but which would then be the time point where you repeat CU-BAT to see how many months longer you'll have to give it to the patient. Does it help?
Yeah, that's a very good question. There's of course no clear-cut guideline. I always do it when I want to change something. So that's the patient was affected for a very long period, and now finally is symptom-free. He's quite reluctant to do anything to the treatment, prolong the interval, reduce the dose. Also, there are no clear-cut guidelines and when to stop also. So what is the mechanism? Xolair works on the patient's cells. This is what we know now. They get, like Sabine has shown, they have first the IG is removed, then the receptor is internalized, and this is how we guess that now the autoantigen is away, and we hope that this the reduction in autoantigen presentation then finally leads to calming down. I would say at the time point when you want to change anything to the medication, because with this test you replace the patient basophils, which are not in the test, by donor basophils, which were not exposed to Xolair. So they are naive. And if there's still something in the serum, you will see activity. And if the activity stays the same, I do not change a lot in those patients.
So excellent talk on the basophil activation test. What is your observation in variability between different labs when you do the basophil activation test? So we sometimes have the impression that there are labs that are more sensitive and give earlier a positive response or a positive result than other labs maybe.
I'm not aware of another lab doing the CU-BAT in Switzerland. We do not send it abroad. So you may have to differentiate. There's the BAT, which is the basophil activation test with patient basophils, or the CU-BAT with the donor basophils.
Ah, all right, okay. Yeah.
This is very important, because the
okay.
BAT with the patient basophils, let's say for drug allergy, is a completely different BAT than this one. It uses the same readout, but in one, you have the drugs as the antigen, and here you have the serum of the patient as the activating factor.
But did you compare, I mean, you have these donor cells that you're using, but did you compare with other centers, let's say in Germany or anywhere else? I mean, if they have different donor cells, there
There's
could be
no standard lab
All right.
offering the test besides the histamine release
All right,
test
okay.
from Denmark, which is a different technology with this fiberglass histamine in the supernatant. We can't send it around. We can only have a look or be precise within our community of donors that they give the same results. So it is not dependent on the donor if you have a positive or a negative result. It might not be on the percentage, but what we are looking for is not that with your blood it's negative and with Sabine's blood it's 87% positive. And this was the IL-3 priming. Okay, this will be the last question, otherwise you don't have time.
In your opinion, it's not necessary to submit the serum in previously eating the serum.
Heating, yes.
Heating.
This is one of the methods that you can do. We did it standardized in the first 3 years of using the test to 56 degrees. Exactly.
30 minutes.
Yes.
The complementation of the
Exactly.
serum.
But
And another question. To found the individual priming, you made a curve with the response with the several doses or
yes, with pooled serum, and this is important that we know a pooled serum with non-responding, so there's no activating factor, and positive with low positivity, middle, and high positivity.
To found the concentration of IL-3 to put in each donor.
Exactly. And what was interesting, it was quite
to achieve the same response.
Exactly, and it was stable over time. That was the good. We were but fearful that the patient, let's say with a seasonal allergy, will have less need of IL-3 during the season than without, but we couldn't show that. That was fortunate. This seems to be a characteristic of yourself, how much IL-3 you need if the blood is in the tube.
Yes, thank you.